How do we monitor a patient who is for vaginal birth after Caesarian section? Patient should be monitored continuously. The patient should be having spontaneous labor before 40 weeks, and he should arrive to the hospital early in labor. Time limit on length of labor: she is not eligible for water birth or for home birth. We have to monitor her pulse and BP periodically, monitor her uterine contractions that they are regular and they are progressing normally. Look for bleeding PV, look for urine color, it should not be blood stained, and keep monitoring for scar tenderness, and look for signs of scar dehiscence, and also partogram should be started. Uterine dehiscence or rupture. Dehiscence is defined as separation of lower uterine scar that does not penetrate the serosa and rarely causes significant hemorrhage. Rupture is complete separation of the uterine wall and may lead to significant hemorrhage and fetal distress. The incidence of uterine rupture is 0.2 to 1% of patients with a previous lower segment Caesarian section, and 4 to 9% in patients with classical T incision, that is the extension of the horizontal by T. And 1/3 of the women with a history of previous classical Caesarian section also rupture before the onset of labor in late pregnancy. There is abdominal pain and tenderness, and often suprapubic tenderness is there when there is scar is threatening to rupture. There can be vaginal bleeding or blood-stained urine, or patient may go in for shock because of internal hemorrhage. The FHS may become undetectable, and fetal parts are easily palpable when there is uterine rupture and the baby has been expelled in the abdominal cavity. Contractions will suddenly stop. There is signs of intraperitoneal bleeding, and there is sudden appearance of fetal distress during labor. There can be late deceleration on CTG. Meconium stained liquor may be present, and there is persistent maternal tachycardia. That is why we should monitor mother's pulse carefully. VBAC, what is the criteria for success? Woman who is less than 40 years with prior vaginal delivery, with spontaneous labor and a favorable cervix, and prior Caesarian section for non-recurrent indication are the factors which are likely to succeed the VBAC. Whereas if there is increased number of prior Caesarian deliveries, of course we don't give them VBAC. Gestational age more than 40 weeks, birth weight more than 4 kg, and induction or augmentation of labor are the factors which decrease the likelihood of success of vaginal birth after Caesarian. Now, why we insist on VBAC if we can? Because there are lots of benefits of natural childbirth. Vaginal birth exposes the child to mother's microbiomes, and in a study published, it decreases the autoimmune diseases such as type 1 diabetes. Children who are born by Caesarian section are more often affected by allergies than those born in the natural way. The reason may be that they have a less diverse gut microbiota, according to a new study. Thank you.